respected doctors. I'm Dr. Oshali from the medical team of USV, and it's a pleasure to invite you all for this webinar on day 4th of ESC Congress 2025 HF updates, recorded by the experts from HFAI itself. And we are grateful to Dr. Ibrahim Omin sir. Under his valuable guidance, we were able to do this. And it's immense pleasure of mine to introduce our moderator, our chairperson for today, Dr. V.K. Chopra sir, having decades of experience, a senior director, cardiac sciences, cardiology, and interventional cardiologist at MEX Super Speciality Hospital, Delhi. It's an honor to have you here with us today, sir. I welcome you on behalf of Team USV and HFAI, and over to you for the further proceedings.
Thank you, Dr. Ashwali. ESC is today the largest heart failure meeting in the world. The meeting this year in Madrid was attended by over 38,000 delegates. Huge, really. There were several parallel sessions going on. Even for the people who are attending there, it is not possible to attend all the sessions. But here we bring you a concise summary of all the sessions. So Heart Failure Association of India, in partnership with USV, for the last 3 days has given you a summary of the previous day's proceedings and the important highlights. Today is the final day, and we are thrilled to have 3 experts with us, Dr. Shantanu Sengupta, Dr. Sandeep Seth, and Dr. Nambirajan. They will be giving their expert comments and a set of panels, Dr. Devesh, Dr. Arun Gopalakrishnan, and Dr. Sriram, who will be presenting the data for their respective sections. So without further ado, let me invite Devesh. Please go ahead and make your presentation. After each presentation, we'll have a brief discussion for 10 minutes and then move on to the next session. Devesh?
Yes, sir. A very good evening, sir. I'll just share my presentation. Is my slide visible?
Yes.
Just wait.
Dr. Devesh, it's in the PDF format,
Yeah.
so
Yeah, just once.
yes.
Can somebody mute whoever is speaking? Okay, go ahead.
Yeah.
You're visible.
Good evening, sir.
Good evening.
Are my slides visible?
Yes.
Yes. So a very good evening to all the panelists and Professor V.K. Chopra, sir, and thank you for this opportunity. So I will be discussing 5 important studies, starting with the effect of heart failure and liver fibrosis and the related clinical outcomes. Second and third studies will be dealing with cardiac amyloidosis in patients with atrial fibrillation, and also dealing with apical sparing in patients with transthyretin cardiac amyloidosis. The fourth study will be cognitive impairment in patients with heart failure. And lastly, I will compare the cardiovascular death in patients with kidney disease. So starting with the first study, we all know that liver fibrosis is seen in patients with heart failure, more towards the terminal stages. It is more importantly seen in patients because of chronic congestion and also because of the underlying inflammatory state that heart failure is. So this study was basically a analysis from the Biostat CHF study, which tried to investigate the association between subclinical liver fibrosis and clinical outcomes in patients with heart failure. So 1,100 patients with worsening or new onset heart failure from the Biostat CHF study were analyzed. Subclinical liver fibrosis was estimated by using a objective non-invasive index, that is FIB4, fibrosis 4 index, which uses age of patients, transaminases, that is AST, ALT, and the platelet count. The primary outcome was all-cause mortality. So what were the results? So the results showed that patients with higher fibrosis based on the FIB-4 score had a progressively greater risk of death compared to those at lower risk. Patients in intermediate risk had a slightly median survival, whereas patients with very high fibrosis had a much higher mortality with a hazard ratio of 2.63. And the values were statistically significant. However, then we tried to adjust for inflammation. So all the parameters were adjusted for inflammatory markers. And despite adjustment for inflammatory markers, the fibrosis remained an independent predictor of adverse outcomes. So it was not only the underlying inflammatory stage of heart failure, but also the congestion due to the worsening heart failure that was leading to over a long period of time, leading to liver fibrosis. So the study concluded that subclinical liver fibrosis, as assessed using FIB-4 index, is associated with poorer outcomes and a higher mortality in patients with heart failure. And even after adjustment for inflammation, like adjustment for interleukin 6 and tumor necrosis factor levels, liver fibrosis remains a strong and an independent predictor of outcomes in patients with heart failure. So should I go on to the next talk, or would there be discussion?
I think let's complete the PowerPoint. Yeah.
Okay. So then the second study deals with cardiac amyloidosis, the transthyretin wild type cardiac amyloidosis, and atrial fibrillation. So we try to do a retrospective analysis to see the impact of rhythm control in patients with wild type transthyretin cardiac amyloidosis. So this was a retrospective single center study which included 240 patients with transthyretin wild type cardiac amyloidosis, and patients were seen and subgrouped with atrial fibrillation and flutter. Patients either underwent rhythm control or rate control, and we compared their outcomes based on echocardiographic parameters, laboratory parameters, and also the number of patients who did maintain sinus rhythm on different rhythm control strategies. So what were the results? Of all the patients with atrial fibrillation or flutter at baseline, only 45% of patients were in sinus rhythm at 6 months, irrespective of the strategy used. The three strategies that were used were amiodarone as drug therapy, pulmonary vein isolation as intervention, and electrical cardioversion. And you can see that all of these were nearly same, but the highest rates were with amiodarone. At 60% patients were in sinus rhythm. Let's look at the results at 12 months. When these patients were followed up over a year, only 1/3 of the patients remained in sinus rhythm, showing that the success rate of rhythm control in this group of patients was very, very poor. Moreover, there was no difference at 1 year between the patients on amiodarone or the patients who underwent pulmonary vein isolation. So no strategy demonstrated consistently superior long-term results as when compared for attainment of sinus rhythm. Now let's look at the lab and echocardiographic parameters. So there was no significant group differences at follow-up between the laboratory and echocardiographic parameters. There was no significant difference in the NYHA class in patients who were either on rhythm control or rate control. So overall, if you see whether the patients received rhythm control or rate control, there was no significant difference in either NYHA class or laboratory or echocardiographic parameters. So the conclusion of the study was that atrial flutter and fibrillation, which is known to be highly prevalent, up to 70% in ATTR wild type cardiac amyloidosis, irrespective of the rhythm control strategies, there is no long-term effectiveness of rhythm control. At 6 months, sinus rhythm was more frequently achieved in patients in rhythm control. However, this did not translate to having any significant impact either on NYHA class or biomarkers or echocardiographic parameters. Thus, rhythm control in this population remains challenging requiring individualized treatment and specialized expertise, which is as expected because in ATTR wild type cardiac amyloid, you would expect very large dilated atria, which would make attainment and consistent sustenance of sinus rhythm a very difficult task. The third study was to compare between apical sparing as seen on echocardiography and clinical parameters in patients with histologically confirmed biopsy proven transthyretin amyloidosis. So, what did we try to evaluate? To evaluate whether apical sparing on echocardiography was a risk factor for disease progression by confirming the histopath from the biopsy samples. So we did a right heart catheterization in 15 symptomatic HFrEF patients with cardiac amyloidosis and compared whether the burden on the biopsy was correlating with apical sparing on echocardiography. And what did the results show? That apical sparing on echocardiography was associated with a higher amyloid burden on the histopathology examination, was associated with greater ventricular thickness on echocardiography and MRI and on biopsy, was associated with higher cardiac biomarker levels like proBNP and troponin values and a lower GLS value. So if apical sparing was present on echocardiography, it was a significant indicator of an advanced stage of the disease with much worse long-term prognosis. So the conclusion, the presence of apical sparing on echocardiography was associated with a higher amyloid load in the LV biopsy, was associated with an increased perigeny score and increased cardiac biomarkers as an extent of amyloid progression, and probably is an indicator of an advanced ATTR stage. However, there's a need of further studies which would investigate apical sparing as a more prognostically relevant marker in this patient subgroup. This brings me to my fourth study, which tended to evaluate the cognitive impairment in heart failure patients who were admitted and had a poor nutritional status. So the aim was to examine whether a low geriatric nutritional risk index, that is low GNRI, is associated with a worse cognitive performance in patients who were admitted for heart failure. So this study included 304 patients who were hospitalized for heart failure. We did a cognitive assessment using Montreal Cognitive Assessment, Symbol Digit Modality Test, and Trail Making Test. And patients were stratified based on their nutritional status with a low GNRI, that is low.
Devesh,
I'll try connect. He
Yeah,
has joined. I
He's
guess.
lost his connection.
yeah, I
Yeah,
lost it.
yes.
And his last slide didn't move either.
I'll try connecting with him.
I think we can still discuss.
My
online.
audio.
So till Devesh joins,
Yeah.
let's see the first four. So let me
Yeah.
ask you, Shantanu, this high Fib score increasing mortality, what do you
Right.
make of it? Is it a cause or is it a cause or it is just an effect of advanced heart failure?
I think it's an association with this study. I mean, these are the limitations of this study. They have not really defined what exactly, but I think it is an effect of the heart failure. And I was more interested in understanding whether it is more predominant with which type of heart failure, whether it is HFrEF or HFpEF, because that has not been thing. But I think it gives us a good insights that this parameter should be looked at in all patients of heart failure. That's a very important concept they are giving.
Yeah, so FIB4 is a very useful score, except that most of us do not practice it, in our patients of heart failure. But if it is
There are
done,
lots of such scores like FIB4, FIB5, and just looking at hyaluronic acid. They are very simple things like looking at a ratio of SGOT by SGPT.
correct.
So these are just basically showing that the liver is congested and a bit of fibrosis. So they are basically markers of that. So as Shantanu said, what kind of heart failure? So if the heart failure is more of right-sided heart failure, these will be more elevated. We've seen this a lot in heart transplant patients. When we work up these patients, the first thing the gastroenterologist will do is he'll order a fibroscan. Moment the fibroscan comes very high, which is expected because the liver is congested, he says very high risk. So they need to understand a congested liver is a fibrosed liver. So that more fibrosis, the more congestion, the worse the patient. So it is basically intuitively going to be a prognostic marker of a sicker patient.
So will it
Sanjay,
make
I
a
want to
difference?
ask you, can I ask you, for a normal physician who advises a fibroscan in heart failure, what level of number is a red flag? So the liver fibrosis is always classified, the fibroscan classified. So what is the red flag? Can give you some insights on when should he be?
I would feel probably he should not order a fibroscan because the fibroscan will always be elevated. Moment you basically a simpler thing like looking at a ratio of SGOT-PT will be a simpler thing to look at because if the ratio is elevated, that means the liver is in trouble. But the cause is the heart failure. So treating the heart failure is important rather than worrying about a liver scan.
Do you think there's going to be a difference between HFpEF and HFrEF? I mean, regardless of how the liver gets congested and fibrosed.
It would be more in HFrEF because in HFrEF, the right side will come under stress faster. HFpEF, traditionally, as we know it, stresses the left system more and very rarely, I mean, less often would affect the right system so fast.
Yeah, I agree with you because in ADHF we look at the Vexus score. It's also a part of a congestion. So I think it is more of the HFrEF than in HFpEF. So I think it is more likely to be in HFrEF, but you can also get it in the acute setting condition. But a very important paper, yes.
Yeah. So let's move on to ATTR cardiomyopathy. Rhythm control is more difficult because of progressive nature of the disease. So Sandeep, what do you make out of this paper and what do you think are the lessons learned?
I was hoping Devesh is there because in the last slide he showed something about p-values being more significant in the biomarkers. So I wanted to ask him that while clinically he said there was no difference in the patients in the end, but he showed a significant p-value in the biomarkers, BNP. So when he joins, he can answer that. But otherwise, intuitively, we feel that in a stiffer heart, you would want to work very hard to make the rhythm control better. Because we've seen repeatedly in our patients with amyloid, patients with HCM, moment the rhythm goes haywire and you develop AF or atrial flutter, patient becomes very sick, very difficult to control.
Yeah.
And we repeatedly try to give amyloid or ask our rhythm experts to try and ablate the patient. But this trial would suggest that, at least this retrospective analysis suggests that maybe it's not going to make a difference. But this is a retrospective analysis, keeping that in mind, at least it doesn't seem to be a very great approach from our side.
Just a minute. Can somebody please contact Devesh to see what is the problem, if he can rejoin? Okay, go ahead.
Yeah, so I think there is another concern apart from the retrospective thing is that ideally the cardioversion in rhythms, we do a cardioversion study, but this was only medically managed. So they have used as cardiologist.
Cardioversion also.
Yeah, they did. Okay, right. Yeah, so I think, but it clearly shows that these are stiff hearts. So that's the reason maybe it was not giving any difference.
Dr. Nambirajan.
Sir, yes, actually, this rhythm control is depending upon the structural remodeling, sir. Amyloidosis, as sir said, it's a chronic stiffening process. So all the previous trials also, as APPAM and other trials, there were no mortality benefits, sir. So we could concentrate on the upstream therapies, modifying amyloid burden, sir, rather than rhythm intervention. Only if the patient is symptomatic or if they have a higher symptoms, we can focus on rhythm control, sir.
Right. So whether you do a rhythm control or a rate control, the end result is not going to be very different. I think that was the conclusion of this paper. Right, Devesh?
Yes, sir. That was the conclusion, sir.
Okay. Then is the question about apical sparing versus non-sparing. I couldn't understand this. Does it mean that people where there's amyloidosis without apical sparing are better off than those with apical sparing? Devesh?
Yes, sir. That is what they have tried to imply, that apical sparing, the patients who had apical sparing had a more worse form, had a more malignant form, had a more cardiac amyloid burden on biopsy and a worse prognosis. They had higher biomarker levels, higher tissue levels of amyloid deposition, and a much worse phenotype as compared to those in which apical involvement was seen, which is very surprising because
So this means
we
that
all
if it
know
is a
that.
diffuse involvement, it is less
Yes, sir.
harmful than apical sparing, Sandeep. You do a lot of
The
biopsy
first
work.
first time, I think basically someone's tried to use apical sparing as a marker. Previously, what we knew ever since ATTR came into vogue, suddenly we had a lot of apical sparing as a marker of amyloid, especially ATTR amyloid. And then we had some data that cherry on top, which is a marker of apical sparing on echocardiography, basically suggests more of ATTR amyloid as compared to, so there are some papers that suggest more of ATTR amyloid as compared to AL amyloid. But I think this is the first paper we're suggesting that this kind of cherry on top is also a prognostic marker. That is one thing. Second thing is there are some initial reports suggesting that you can make a ratio of the strain at the apex versus a strain at the base, use that as a ratio and try to create a prognostic marker of that also. So people are trying to look at the differential strain in different parts, which is in a way the cherry on top, and try to create ratios out of that and create some kind of prognostic markers. But whether these are better than our traditional prognostic markers for heart failure or simple biomarkers like BNP will come out maybe in the future.
But Sandeep, tell me one thing. We do see a lot of AL amyloid, much more than what we see as ATTR. We also see a lot of apical sparing, and ultimately they turn out to be AL amyloid. Do you think that same thing applies to AL amyloid also, which could be associated with chronic renal failure or various rheumatological conditions and so on?
I don't think so because I have a simple rule of thumb. For most of my amyloid patients, most of them are actually AL amyloid. If we catch them early, if we catch them when they're class 1 and 2, if the cardiac component we just happen to catch because they had renal amyloid or something else, if they're class 1 and 2, we'll find that the cardiac problem is much less. Their biomarkers are fairly okay, well controllable, and they'll do fairly well because the cardiac disease is relatively less. Their renal disease or bone disease is much more, and that is controllable by chemotherapy.
Right.
But if they come to us with class 3, 4 heart failure, then the prognosis is bad no matter what we do, and we will lose them in roughly 2 years. The median survival in our series of more than 40 patients is roughly 2 years. As compared to ATTR amyloid, I don't have so much experience, but with the families, definitely they come less sick. They don't come in such a florid bad state. But if you keep an index of suspicion low and you do a biopsy, I straight away do a cardiac biopsy. So if you do a biopsy fast and you somehow get the drug to them, if they can afford it, they do very well. I've had some patients with mixed amyloid also. So the biopsy showed both AL and ATTR. They do well with a mix of chemotherapy and tafamidis, though this is not recommended. And wherever I've talked to experts outside, they say we are not allowed to give both. They either give chemotherapy for AL or they give tafamidis. They are not allowed to give both. But I've tried giving both to at least one patient, and he's done fairly well on a combination.
So Sandeep is one of the people who has done probably a large number of biopsies in these people. Most of us rely on technetium pyrophosphate scan, but Dr. Sept goes straight away for biopsy, which is actually the gold standard. But is there a difference between apical sparing and non-apical sparing, Sandeep?
I don't think so. This is the first time I heard anyone try to look at it
Yeah.
that way.
I was a little surprised with this, but anyway, that's what it is. So, okay, Devesh, time is short, so go ahead. You were with cognitive impairment markers of advanced heart failure. So just conclude that
Yes.
so that we are slightly
So,
behind.
yes, sir. Yes, sir. So to conclude, patients with malnutrition, as measured by geriatric nutritional risk index, is linked to poorer cognitive performance in patients with heart failure, particularly when measured via global cognition, via MoCA, and processing speed. executive function and psychomotor speed as measured by TMTA performance scale was not that significantly deranged. However, global cognition and processing speed was very significantly deranged in patients with malnutrition and heart failure. However, there is a scope for further research to delineate and clarify the mechanisms and the relationship between malnutrition and cognitive decline. Coming to my last talk, it is a comparative analysis of cardiovascular death in patients with either CKD versus acute renal failure and to see the cardiovascular outcomes. So this is just a retrospective analysis which was done for patients over 2 decades in United States. And we compared the mortality trend in patients with cardiovascular disease with either chronic kidney disease or acute renal failure. And we stratified the analysis as per gender, race, ethnicity, and the geographic region. So what were the results? Over the span of 2 decades, there were 5,65,000 deaths due to patients with CKD and cardiovascular disease, whereas it was only 2,48,000 in patients with acute renal failure. So half the number of patients of acute renal failure as compared to those dying due to CKD and cardiovascular death. The age, as would be expected, more higher the age. So aged patients aged more than 85 had the highest crude mortality rate. There was no surprise there. And there was a significantly higher mortality in males as compared to females, which we know from prior studies. And mortality was much greater in patients with CKD than in the acute renal failure patients. When we look at the racial trend, the non-Hispanic whites showed the highest mortality, both in the CKD and in the acute renal failure arm. And if we look at the state-specific trends, because this was a US population, California reported the highest overall mortality, both for chronic kidney disease and acute renal failure, whereas Alaska had the lowest. So the study concludes that over a span of the last 2 decades, cardiovascular mortality in patients with CKD and acute renal failure and underlying cardiovascular disease has declined significantly, but remains high, especially in non-Hispanic whites, in males, and in elderly more than 85. CKD mortality was highest in the Midwest, whereas acute renal failure leading to death was highest in the southern parts of US. California had the highest state-wise mortality. These findings somehow show that there is a significant demographic and geographic disparity, emphasizing the need of more targeted intervention in sectors with the highest mortality. Thank you so much.
Thank you. Dr. Nabirajan, let me start with you. Cognitive impairment. Do you think it is why is it not just a marker of advanced heart failure rather than being an independent risk marker?
Yes, sir.
Dr. Nabirajan, you are muted. Dr. Nabirajan, can you please unmute? Yes, Dr. Nabirajan, why is it not just a marker of advanced heart failure?
Sir, yes, sir. Almost all the patients are undernourished and they have chances for this nutritional status will be much affected. So this could be a modified determinant of cognitive health, sir. So the nutritional screening should be included in all heart failure patients as a marker of cognitive impairment, sir.
I think, Sandeep, what do you think? You run a heart failure clinic. Is it that with proper guidance about nutrition, with trained nutritionists?
What is the age group of these patients, Devesh?
Sir, 5th to 7th decade, sir.
And
So there's
the country is US or which country?
Say US, sir.
So I'm very surprised that they are talking about malnutrition in the US. Because frankly speaking, I mean, by standard things, most of the patients of heart failure that we see, probably all of us would be seeing, are by visual thing, they don't look malnourished at all.
Yes, sir.
Yes.
So I'm very surprised what kind of malnourishment are they picking up. And it's unlikely that our patients are better nourished than the US patients.
So that's why I asked you, is it not just that these are too advanced when there's a loss of protein, lack of adequate intake, and so on and so forth?
Yeah, maybe because we need to look at this paper more, because what kind of patients are they and what kind of malnourishment and what indices are they seeing? Because maybe if they're very advanced patients and what kind of cognitive test, because the patient is very sick, he will anyway not perform well on any kind of cognitive test. If you ask a patient who's very sick to start doing advanced mathematical tests, he will be too sick to do any kind of mathematical tests and all. So I don't know. Because most of us anyway give all these patients nutritional advice and give them vitamin supplements, calcium, iron supplements. We need not necessarily give them iron injections to all, but we at least give them oral iron to most of the patients. And plus, I'm sure we all give them iron injections also. So we do take care of the nutritional component for all our patients.
Oral really doesn't work, no, Sandeep, in these people.
No, at least I give both. I give both the things. I give a shot of iron,
Yeah.
and then I add the oral iron also. I do both things.
So this GNRI index, geriatric nutritional risk index, incorporates only two things. One is albumin, the serum albumin, and the second is the ratio of the current weight of the patient divided by the ideal weight. And the ideal weight is calculated for any individual by measuring his height and standardizing it for a BMI of 22. So let's say a patient who is at a much lower weight will have a significantly lower GNRI. And GNRI was an objective index that was used not for patients with heart failure, but for any elderly patient who was hospitalized. So it has been now extrapolated to patients who are being admitted for advanced heart failure and for heart failure and heart failure hospitalization. And that is how they have seen for cognitive decline in such patients.
As a last comment, let me ask you, what new have we learned from this? We know people who are malnourished for whatever reason with advanced heart failure, they will have a higher mortality. It will be more in people who are elderly, who are more sick, who have more advanced heart failure. So what's new in this?
So I think we have been looking at sarcopenia, we have been looking at iron deficiency. This is a new insight which we are trying to give, that we have to also look for malnourishment by this criteria, which Devesh has been telling. So if we can more focus on the nourishment, and the main focus is albumin. So the proteins is the key. We have to be very careful, and the body weight. According to the requirements. So I think this gives us very good insights about the progression of the disease. That's what I feel. Yeah.
Okay, so let's quickly go on to the last paper. Shantanu, over to you. CV death in CKD versus AKI. Is there any surprise? We know that a person who has CKD and they got heart failure, they are more likely to die. A lot of AKI people will have a reversible factor. And if you take care of that, they return to normal. So, I mean, what's so great about this?
But I think, this is what is expected. The biggest advantage of this study is a big trial. I mean, 21 years is a big data, but I think it also gives you an idea that the way of treatment all across US is not the same. So they have patches where the Midwest has the maximum mortality with CKD. So they are giving regional trends. So the only biggest advantage is it is a big data. The limitations, it's a retrospective analysis, but no new information is coming. I think we are aware of this.
Others? Dr. Nambirajan, your comments?
Yes, sir. Yes, sir. All these persons who have a hypoperfusion, low cardiac output, they are prone for acute kidney injury. So it's a well-known thing, sir. And they are in the due course, they will go for CKD. So it's been taken care by all the heart failure treatments. So I don't think anything new in this.
Sandeep?
like in the data is that Alaska has the best results as compared to California. That means Alaska has the best medical care
Yes.
for heart failure in the US as compared to California. You would have thought California would have the best medical care.
Not so.
That means
California is such a mixed population, huge number of destitutes, homeless, etc. They all
so
land in
Alaska probably has focused medical care because we are closed community, a smaller community,
smaller community.
everyone getting uniform care. And
Okay.
these are all elderly people, 85 years plus.
California has the
Very
highest
elderly.
mortality, sir. As such.
Okay. Thanks, Devesh. Let's go on to the
Yes.
second speaker. Arun, over to you.
Okay, sir.
Good evening. First, I'll go to the 2025 ESC guidelines for the management of myocarditis and pericarditis. There are some changes that has happened from the last guidelines, and this guideline focuses a lot on endomyocardial biopsy and the use of CMR. That is given so much of weightage, so much so that it is considered endomyocardial biopsy or CMR proven myocarditis versus negative myocarditis, based not just on other investigations alone. So that's so much a focus on these two investigations for the diagnosis to rule in and to rule out. For that, they use the Lake-Lucey criterion for the CMR, and they've given two important points, that is the T2-based criteria of myocardial edema or T2 score, T2 weighted scores, and the T1 weighted changes on the ECV values and the absolute T1 values as well. So it should be suggestive non-ischemic myocardial injury, and if it is supportive of myocarditis based on CMR, one can rule in myocarditis. So that is one important thing that has happened with early recommendation of CMR to diagnose myocarditis, not just based on lab parameters alone. And this is how it comes at present. CMR and endomyocardial biopsy come early in the evaluation algorithm, and somebody who has got high-risk clinical features can be taken up for biopsy upfront. And if there is no high-risk clinical features, patient goes straight away for a CMR, and then you risk stratify, and then the subsequent part of the algorithm is not too different from the earlier ones. For want of time, I have to stick only to the salient aspect of the guidelines. Even for outpatient evaluation for myocarditis, one can evaluate using a troponin, but then for the relatively stable patient, CMR scans is still to be applied early in the evaluation. For pericarditis, the evaluation is pretty much similar to the earlier one. You risk stratify, and the high-risk patients are advised admission, while the others can be managed on outpatient basis. But there is some difference in the management for myocarditis and pericarditis. Here, as mentioned earlier, CMR comes early in the algorithm. So does the endomyocardial biopsy in patients who are sick, high-risk patients, those who are hemodynamically unstable. It's given a class 1 recommendation, but based on level C recommendation of expert consensus. And this guideline focuses something more on recurrent, that is inflammatory myopericardial syndromes. They've tried to bring in a concept of recurrent myopericardial inflammatory states, which can actually be a harbinger of a long-term heart failure. And that needs evaluation. That is one reason they have focused so much on CMR and biopsy as well. So much so that they have even recommended the use of genetic testing in recurrent myopericardial syndromes, which was not there in the earlier recommendations in any of the guidelines. So those patients who have got a family history of with a definitive myocarditis or pericarditis, with a family history or a history of severe ventricular arrhythmia with significant late gadolinium enhancement with recurrent myocarditis or pericarditis, are advised for genetic testing. And another thing that is new in the guidelines is there's a specific recommendation on when autopsy is to be advised. Comprehensive autopsy is recommended for all patients so less than 50 years of age with sudden cardiac death to evaluate the presence of acute myocarditis as a potential cause of the same. That is something new. And regarding the treatment of myocarditis, they've tried to classify it based on the types, but the emphasis is on oral prednisolone. IV nasal prednisolone comes down the line, and so do other medications. So oral prednisolone is the treatment of choice. Some of the other relevant points in the treatment of myocarditis, colchicine is advised to prevent recurrences. It is given a class 2A recommendation now. It has come up. And beta blockers is advised for at least 6 months in patients with acute myocarditis, especially those with troponin elevation, to control symptoms and to prevent arrhythmias. For pericarditis in adults, there is a significant change compared to the earlier existing guidelines in that now the class 1 management is a combination of an NSAID or aspirin plus colchicine. It never used to be, all previous recommendations considered pericarditis as a benign disease where it is managed primarily by pain relief medication, but here we've got a lot of emphasis on combination therapy upfront. And those who do not have a response to the initial combination therapy of NSAID plus colchicine or aspirin plus colchicine can be considered for low or moderate dose of steroids plus colchicine or triple medical therapy with the steroid plus NSAID plus colchicine. And if in session, the person is a candidate for anti-IL-1 agent, that's anakinra or rilonacept, and that's also given a class 1 recommendation. So that is the salient points in this slide as well. Anakinra, the combination of colchicine and aspirin or steroid plus anakinra comes up. And steroid as such is has been downgraded to class 3 for pericarditis without a specific indication. And there is also an emphasis for the first time, a wearable cardioverter defibrillator has come into the recommendations in the management of myopericarditis, where somebody who has got myopericarditis and had a sustained ventricular arrhythmia, they can be advised a wearable cardioverter defibrillator for the first 3 months, 3 to 6 months, as a concept of bridge to recovery. So bridge to recovery now can be used for the myocarditis, the post myocarditis phase as well, in the setting of arrhythmia, not just in the background of LV dysfunction. And also they've tried to give a list of red flags which can suggest adverse outcomes in people who present with acute pericarditis, and they've divided into major and minor criteria, which are suggestive of risk markers of adverse outcomes in these syndromes. And there is another new thing in the guidelines, that is a new terminology called immune checkpoint inhibitor associated myocarditis. Now that's a class of drugs which are primarily cancer chemotherapeutics, which act on by immune modulation. And in this entity, steroid is the primary therapy is advised, and then the other drugs can be used. So here, when we have a specific subset where steroid comes right up in the list, it's immune checkpoint inhibitor associated myocarditis. There is also a specific recommendation on an entity called inflammatory cardiomyopathy. Inflammatory cardiomyopathy is they recommend to treat with the standard guideline directed heart failure treatments for treatment of the LV dysfunction. And the other evaluation workup is similar to other forms of myocarditis. And there is also, they've also tried to give recommendation for post-cardiac injury syndromes, where interleukin-1 antagonists have been given a class 1 recommendation with refractory post-cardiac injury syndrome to prevent recurrence and progression of this condition to constriction. It's a class 1 recommendation of IL-1 antagonists. So that's something which is new. And colchicine has a class 2A recommendation here as well. And for purulent pericarditis, pericarditis and surgical window is known, but now the intrapericardial fibrinolysis for purulent pericarditis is given a class 2A recommendation with the level B evidence. So contrary to earlier practice, now we have the option, it has been given a higher recommendation for intrapericardial fibrinolysis. Regarding cardiac tamponade, there is something, most of the criteria are the same, but one specific thing that has come is the ratio of, while RA collapse is generally considered more sensitive, there is a specific aspect of the RA collapse which is considered to be significantly specific. That is the duration of the RA diastolic collapse as the ratio of the cardiac cycle. When it's more than 1/3 of the cardiac cycle is more than 0.34, it is considered as a specific marker of cardiac tamponade. And there is also a discussion on pregnancy, lactation, reproductive issues in the context of myopericarditis, in that NSAIDs, the second point is interesting. NSAID should be considered in pregnant patients with pericarditis until the 20th week to prevent an incessant or a recurrent course. And that is a class 2A recommendation in pregnancies. Now, NSAIDs in general used to be considered as contraindicated in pregnancy, but now they have, it's a level C recommendation only, but that is something of interest. And again, down the course, colchicine may be considered in pregnant patients with pericarditis, and also anakinra may be considered during pregnancy and lactation pregnant patients with recurrent pericarditis who are unable to use alternative therapies to prevent an incessant or a recurrent course. And ESC now has come up with this pocket app guidelines, and the listeners can actually take a screenshot of this to get the pocket app. The whole thing will be there on your mobile phone. So that is the first set of guidelines.
Is there another set?
There is another set. There is cardiovascular disease in pregnancy, sir.
We need to speed up, Arun, because there's hardly any time.
Yes,
15 minutes are up. So shall we discuss this first quickly? Sandeep, you have had a huge experience of biopsies. Early biopsy in all myocarditis or only in high-risk people?
We should move towards early biopsy in all patients. The reason is that the biopsy pickup rate is somehow not very high, and as a result, people have stopped doing biopsies. Whenever worldwide we have tried to develop protocols for biopsies and based on biopsies tried to develop guidelines, we failed because we end up doing biopsies late. We feel that patients will improve, and as a result, by the time we do a biopsy, we don't pick up anything. We recently concluded a ICMR sponsored study where we did biopsies in all patients whom we picked up within 3 months. But the result was that out of almost 100 patients which we shortlisted, and then we analyzed them, we took biopsies, we froze all of them, and then we analyzed only the patients whom we had picked up within 3 months. So that over a period of 2 years was only 30 patients. Then we had stored all the samples, and when we looked at the data, serological evidence of viruses was there, IgM positive, was there in about almost 1/4 to 1/3 of the patient, but that was more of adenovirus than that. But when we looked at the biopsy, initially we couldn't find any way to find out the tissue. Ultimately, our forensic colleagues helped us. They picked out the DNA from the biopsies. And then we found parvovirus, which was only present in the biopsies. So parvovirus was not coming out on the serology. Serology was negative for parvovirus. It was not present anywhere, but it was there in the biopsies. So that means if we had picked up the parvovirus initially, possibly we could have treated these patients with IVIG or something. We've also found evidence of CMV, which was positive both in the serology, this was IgM, and also in the tissue. That means many of these patients were actually positive for CMV. Some of these patients are positive for parvovirus in the tissue. So possibly some of these patients could have been treated with antiviral agent. That means you could have given them interferon or IVIG. But see, these were samples collected over a year. By that time, they had lost some of these patients. Some of these patients had recovered, or they were still going on. So if we manage to standardize techniques to pick up these viruses quickly, currently, even worldwide, only Germany is doing these studies still under Schultes and very few centers there, and I think some centers in Italy are also trying to develop these techniques to look at these viruses. But worldwide, very few centers are doing this.
Yeah, Sandeep,
But doing
yeah, so sorry, we are short of time, so I'm sorry to rush you, but tell me, person presents to you with acute myocarditis. The person is hemodynamically reasonable. Would you straight away go for a biopsy?
my protocol is I'll straight away ask for the inflammatory markers, ESR, CRP, ferritin,
Available
D-dimer.
next day.
They'll come within a day or two. I'll ask for an MRI. MRI, usually the date will come within 2-3 weeks at least.
Oh,
By next
but
week, I would have done a
if the
biopsy.
MRI date comes within a day or two, as it
It
happens in
doesn't
many
come for
centers.
it doesn't come for us, but
Yeah, no.
I would do a biopsy by next week.
Okay. So tell me you see, the thing is with viral markers, when you send viral markers, how long does it take for the results to come?
I send them outside, I outsource them, so it comes within 4-5 days. IgMs.
Okay. So that is pretty quick.
Yeah, but sir, the guidelines are telling that if the patient has a sudden cardiac arrest, then only the biopsy is now given. So with our kind of protocol, with the lack of biopsy thing, it's not available everywhere. We can get a CMR, we can get the viral biomarkers within 7
So
days.
MRI
don't you
and
think,
biomarkers and viral markers. So my philosophy is that if we get anything to suggest that there's inflammation going on, then we should be more aggressive with giving anti-inflammatory therapy, which is steroids. We are used to giving steroids for rheumatic fever. So we're used to using steroids. They don't cause harm in the short run. And I use a protocol like rheumatic fever. I give it for 6 weeks full dose, then I taper it down to 5 to 10 milligrams, and then I continue that for at least 6 months, but with very close follow-up. After 6 months, I take a call on whether I want to give it for a year or so.
Okay. So for physicians, 30-second summary, Sandeep.
I think we should try, if you're suspecting myocarditis, if you have ESR CRP positive, this is myocarditis, send it to a specialized center where an MRI can be done, interpreted properly, and then treated properly, because your window period of treatment is the first 3 months. Don't wait for 6 months to 1 year when it's too late to treat.
Okay, so let's move on to pericarditis. Dr. Nabirajan, let me ask you. The speaker said something, NSAIDs for 3 to 6 months to be given before starting steroids. Isn't that too long? Which pericarditis goes on for 3 months or 6 months?
So normally we don't see that much course, but they advise a cocktail therapy with the 3 drugs. That could be through some better movement in controlling the pericarditis. Colchicine, aspirin, and NSAIDs. They said 3 can be combined.
But Arun, you mentioned, is there any data? I mean, what was the support for that? Somebody comes to you with acute pericarditis, you start them on NSAIDs. How many pericarditis will go on for 3 months or 6 months?
No, sir.
Unless I read it wrong.
No, so this is something totally new from our practice, sir. I fully agree, sir.
And inflammatory myocarditis again. Shantanu?
I think what's happening for the pericarditis, if I can add, what they are trying to do is to prevent the recurrence of the relapse, because they have now come up with a new entity that if there is a recurrence after 6 months, then the other line, the anti-interleukin drugs are happening. So NSAIDs plus aspirin plus colchicine for a longer therapy, and then give us steroids. Now, regarding, so another thing is pericarditis can also have myocarditis. So if you have pericarditis, myocarditis, go for genetic testing. So that they're very clear about it, that if you are suspecting peri plus myo, then a role of genetic testing should be done. And we have now very good genetic things which are available. I mean, I had sent it like 14,000, 15,000 rupees. The labs are giving in 3 weeks, the genetic markers, all the genetic markers.
The other thing is, in our context, in inflammatory myocarditis, tuberculosis has always to be kept in mind, apart from sarcoid that we see. What about post-cardiac injury, immune checkpoint inhibitors?
Yeah, this is something new which has come up. I mean, immunocheckpoint inhibitors, I have not come across. Any experience with you, Dr. Sept, Sandeep sir?
No?
Yeah, waiting to see them, but I think people are starting to use them. But I think it's apparently a very expensive form of therapy.
Mm.
So very few oncologists have actually used them. It's just one or two patients here and there. But we know that it's associated with a lot of cardiac side effects.
Yeah. So, and
So
finally,
not
yeah, sorry, go ahead.
no experience so far.
So finally, Arun, you also mentioned about duration of RA collapse as a marker of tamponade. More than 90%, or was it 100%?
100% specific is what they meant.
Okay. Shantanu?
Yeah, so I think the most sensitive is diastolic RA collapse. Most specific where was LV collapse. But now they have added more, more than 0.36 of the cardiac cycle is also 100% specific for RA collapse. So it's a very important thing because you are getting a sensitive and specific marker together. So
Is it more sensitive, you feel?
yeah, it's pretty good. So RA collapse is the first, diastolic RA collapse is the first. And if you have duration, it can be specific. Very,
Right.
very good information.
Right. Arun, for the next thing, guidelines, can you quickly summarize? Because, we are almost done with your time, but
Yes, sir.
can you quickly summarize that in the
Yes, sir.
next 5 minutes?
Yes, I'll do that. Only the most relevant points I'll tell.
Yeah. Less
This
than
is
5 will be even better.
Yes, sir. I'll keep a countdown on that as well. So this is the ESC guidelines released on the management of cardiovascular diseases and pregnancy. The pregnancy heart team concept is not new now. Some of the important things that they have come up with a modified WHO 2.0 to determine how severe the pregnancy and cardiovascular diseases, and those who are class 2 and class 3 above need evaluation by pregnancy heart team. And something which is new is they recommend the use of BNP and NT-proBNP prior to pregnancy in women with heart failure of any etiology. That is something new prior to pregnancy, and that's a class 2A recommendation with the level of with level B evidence as well. Vaginal delivery is recommended for cardiomyopathy. It's nothing new, but it has been emphasized at the class 1 recommendation. And there is a lot of emphasis on the use of beta blockers in pregnancy. Now, it was used to be contraindicated in pregnancy to a significant extent, but there is so much emphasis on beta blocker usage in pregnancy in cardiomyopathies in this recommendation. And coming to CPVT, they've advised the use of flecainide in addition to beta blockers for those who have got cardiac events such as syncope or cardiac arrest during pregnancy. And another thing is in peripartum cardiomyopathy, once the LV has improved, the question of how long to give to reassess, and also they come up with a recommendation of at least 12 months after complete recovery. And contrary to the other guidelines of continuation for indefinitely, but here they've come with a time period of 12 months. Then with congenital heart disease, all Fontan patients need evaluation of the pregnancy heart team. Now that is clear. And PH, some things which has come up is that besides endothelial receptor antagonists, riociguat and selexipag are also considered class 3 in pregnancy. Then regarding DVT pulmonary embolism spectrum, now they should be considered like non-pregnant status. It is very clear in all their detailed recommendations. They have mentioned that no investigation or treatment should be withheld, be it low molecular weight heparin, be it CT pulmonary angiography or invasive or surgery. Everything should be managed like a pre-pregnant patient. Regarding coronary disease and pregnancy, something new is that statins may be considered during pregnancy in those with atherosclerotic cardiovascular diseases. Now that is come up with a recommendation, all with a class C. Similarly, if DAPT is required, clopidogrel is the P2Y12 inhibitor of choice during pregnancy. Regarding hypertensive disorders in pregnancy, the management of drugs, now they have classified that more than 140/90 is the threshold to treat. And in severe hypertension, the drugs of choice are IV labetalol, urapidil, nicardipine, or oral short-acting nifedipine or methyl dopa. And IV hydroxyzine, they push it down as a second-line option. That is something that has come up here. And regarding how to resuscitate pregnancy patients with cardiac arrest during pregnancy, now they have come up with the statement that continuous manual left uterine displacement during CPR in pregnant women more than 20 weeks gravida is recommended during resuscitation. And also, it is recommended to establish IV access above the diaphragm to ensure that the IV therapy is not obstructed by the gravity uterus, the new statement that has come up. And again, there is no role of prophylactic TPA for asymptomatic complete heart block in pregnancy. So they put it as a class 3 recommendation. And another thing is, when a pregnant lady has got a significant valve disease, whether to operate during pregnancy or not. Now, the new statement is that it should be considered, valve surgery is considered only when there is a maternal mortality risk and other treatment options have failed. And that's a class 2A recommendation. So that's how. Among the contraindicated drugs, SGLT2 is also considered as a contraindicated drug. Then some of the recommendations, the previous guidelines have been more, have got upgradation. That is regarding antibiotic therapy for endocarditis, class 3, we have moved to class 2. Beta blockers is already mentioned. Pregnancy, everything has come through to a heart team, a pregnancy team recommendation.
Okay.
And regarding the congenital heart disease in pregnancy as well, all consensus statements have got stronger recommendation. That is in general what has happened. And regarding whether to use balloon aortic valve or valve interventions in pregnancy, here they have actually put TAVI as a 2B indication during pregnancy. That is something new. Other drugs can be considered. Sotalol is another drug which they have considered as a drug which can be used in pregnancy in ladies with ARVC. The others, I think, are pretty much something coming to the last is the VT management. It is in VT management in pregnancy is primarily cardioversion. There's no question regarding that. And CPVT patients may be given IV beta blocker. So that is how it is. So I think for short of time, I'll wind up here.
Okay, Arun, thank you so much. So I think one thing which stands out is resurgence of beta blockers. They were once looked down upon, and now it is mentioned that they are totally safe. Dr. Nabirajan, what do you make out of it?
Yes, sir. Initially, we were not giving beta blockers, sir, but it has come up in this thing. And my point of view regarding this peripartum cardiomyopathy, sir, we are seeing often a lot of cases, and they have advised genetic testing for peripartum cardiomyopathy. But one thing they have not mentioned, if I couldn't watch, bromocriptine we have started using now, sir, in peripartum cardiomyopathy. What is your say, sir, regarding the bromocriptine in peripartum cardiomyopathy?
So bromocriptine has had a mixed kind of a thing. Karen's liver in South Africa and Germans, they use it a lot. Many other Europeans and Americans don't use it. I think their opinion is still divided. Sandeep, what do you say?
I think the data in terms of data is limited because the data is only from 2 or 3 sets of investigators. They publish one paper, then they publish a second paper with more patients. Same with 2, 3 groups only. But I have used it in some patients. But you have to use it cautiously, go up on the dose carefully, add antiemetics, add anticoagulants. But it seems it does work, or maybe the disease improves spontaneously. But in terms of peripartum cardiomyopathy, I've had some patients where there's a genetic component also. So there was a family history. I lost the father, then the daughter got cardiomyopathy when she was pregnant, but then I treated her aggressively with everything possible. So I put her on strict bed rest for 6 months, bromocriptine, everything. Surprisingly, her heart function from 20% came up to 45%. That means that these are mixed cardiomyopathies. There is a genetic component, there is an inflammatory component, perhaps, there is a peripartum component. Maybe they're just prone to various kinds of cardiomyopathy. So probably whatever we know of, we should do. Give everything.
The thing is, one case doesn't prove anything. No, maybe he could have recovered otherwise also. But I was talking to Karen Sliver. She is on most of the chair of most of the guideline writing committees on the subject, and they very strongly feel about it. But then, as I said, it's a mixed thing. Shantanu, peripartum cardiomyopathy stop treatment after 12 months after assessing cardiac functions. Which is the most sensitive? Is it GLS or anything else that you would look at?
Yeah, so I think a lot of work has come up that it takes minimum 6 months to 9 months for the GLS to return to normal. So I think this 12-month concept has come up from there, because even if the LV ejection fraction may improve, but the GLS takes time to improve. And there has been some work which has shown that it takes almost 9 months to recover. So I think the 12 months has come from that ballpark, and understanding that we have to counsel the patients for subsequent pregnancies, because this
that of course.
can again recur.
So, Sandeep, are you comfortable stopping the treatment at 12 months if GLS has returned to normal?
I don't stop for the simple reason that most of our patients will be planning, wanting to do a second pregnancy. They will not listen to us at all. So I tell them very simply, don't stop the drugs at all. I'll ultimately put them on a once daily ACE inhibitor and once daily beta blocker, and I'll tell them to continue lifelong, like we do for all other recovered heart failure
Okay,
patients. I
great.
tell them
But
continue.
suppose they have completed their family and now she wants to know whether she can stop or not.
I'm not comfortable. Stop it.
So
So
I think,
there is no data supporting this
I
guideline.
don't think the last
But-
word on this has been said. More data needs to come up and more studies need to come up which substantiate this particular aspect. Any other comments by Dr. Nambirajan or?
It's like unlike other heart failure with reduced ejection fraction, as Sandeep sir said, we need to continue, sir, lifelong. Even
Right.
the pregnancies are over, we need to continue.
Okay, so for the audience, the message is still mixed, although this study says, but I think the conventional wisdom and the guidelines still suggest that it should continue. GLS is a very, very sensitive marker. And subsequently, after a variable period of time, you have to assess case by case, depending upon patient's wishes and the trajectory of the heart failure events. Okay, so then we now finally come to last presentation, not the least. Sriram, over to you. Tell us what have you learned?
Yes, sir. Am I audible, sir?
Yeah, share your screen and show your slides.
Yes.
Full
Is my
screen.
screen visible?
Yeah, it is. Make it full screen, please.
I made it full screen, sir. On my screen, it is full screen.
Is it? For others, is it full screen?
Yeah, it's okay, sir. Yeah. It's
Okay,
fine.
go ahead.
We can zoom our
Ah.
screens.
Good evening to one and all, and thanks for adjusting with my time request. And thank you to Heart Failure Association of India and USV for giving me this opportunity to discuss this updates from the ESC Congress today. So today we have a total of 6 topics which we are going to brush upon. First one is a prospective real-world study where they evaluated the long-term efficacy and safety of sacubitril valsartan in chronic heart failure patients with reduced ejection fraction. Second one is a SGLT2 inhibitors and ARNI, whether they improve long-term heart failure outcomes in a Southeast Asian cohort. Third is whether the effect of sacubitril valsartan and vericiguat has any significant impact on the cardiac CGMP augmentation and hemodynamic improvement in patients with heart failure with reduced ejection fraction. Fourth one is the impact of sacubitril valsartan on the sleep apnea parameters in heart failure patients. Fifth is to get an insight about the ESC Heart Failure 3 registry, whether what are the important parameters driving the quality of life in patients. And last is an introduction to a concept called as registry-based randomized clinical trials. So let's discuss the first one, which is the long-term efficacy and safety of sacubitril valsartan in chronic heart failure with reduced ejection fraction. This included the cohort of patients who were started on ARNI alone before the introduction of SGLT2 inhibitors. It was from January 2017 to September 2022. Stable heart failure with reduced ejection fraction patients were taken at a single center, and demographic, laboratory, and instrumental data and periodic follow-ups were done. So the results are as follows. Around 79% received maximum tolerated ARNI dose throughout the follow-up, and they were well tolerated without significant hypotension or creatinine rise. The clinical outcomes in the treated patients, there were significant effects in reduction in in the number of heart failure hospitalizations, the intravenous diuretic dose required, and the anti-proBNP levels. Though there was a difference in the number of urgent heart failure visits, it was not significant, and same with respect to increase in the LV ejection fraction. So overall, were around 7.4% patients died from cardiovascular causes during the follow-up. And those patients who had to discontinue the ARNI due to either hypotension or reduced ejection, EGFR or intolerance, these patients, it was noted there was a significant increase in the cardiovascular events after stopping ARNI. So these basically results confirm the long-term efficacy and safety of ARNI in a real-world cohort of heart failure with reduced ejection fraction and highlighting the importance of the guidelines recommendations. Second is a multi-state model from a real-world Southeast Asian cohort where SGLT2 and ARNI improve long-term heart failure outcomes. So it was to compare long-term effects of early SGLT2 inhibitors and ARNI versus the traditional GDMT in preventing hospitalizations and mortality using a multi-state model. It was a retrospective study. Around 11,000 patients were taken with heart failure, and the patients without any heart failure specific medications were excluded. They were categorized into the following groups. One, those who were receiving basically these drugs based on whether from the time of diagnosis of heart failure within 6 months they had to be started. The number of patients on only SGLT2 inhibitors, some on only ARNI, where GDMT with more than one heart failure medication, and full GDMT, which includes our traditional four-pronged approach. And analysis was to estimate the transition probabilities from initial heart failure, first hospitalization, second hospitalization, and recurrent hospitalizations, along with all-cause mortality. What was noted that in the stable heart failure state, at 10 years, no hospitalization, which was noted. Around 88% of SGLT2 inhibitors receivers did not get hospitalized. Those on full GDMT, 78% were not hospitalized. ARNI alone, 74% were not hospitalized. And GDMT, which according to the previous category was more than one heart failure medicine, around 58% were not hospitalized. Similar results were seen in the probability of first hospitalization as well, where the SGLT2 stood out with respect to its glaring reduction in the first heart failure hospitalization. And all-cause mortality, again, we can see that the maximum reduction was in cases of SGLT2 inhibitors. The lowest mortality is in those receiving SGLT2 inhibitors, followed by those on full GDMT, followed by ARNI alone, followed by more than one traditional four-prong medicine. So conclusion was early initiation of SGLT2 and ARNI significantly reduces the heart failure hospitalizations and mortality as compared to traditional GDMT. SGLT2 inhibitor demonstrated the strongest protective effect across all the heart failure phenotypes and maintaining stability and preventing hospitalizations and reducing long-term mortality. And full GDMT, though it appears to be very attractive, it showed better long-term outcomes than GDMT alone, but it did not surpass the effects of SGLT2 inhibitor alone. So hence it is what we get to analyze from this is that early SGLT2 initiation can be a cornerstone therapy in heart failure management, irrespective of the ejection fraction. Third study was the study of cardiac cyclic GMP augmentation and hemodynamic improvement in patients with HFrEF. And this was from patients who were on sacubital valsartan and on vericiguat. So whether there was any association between the augmentation of CGMP and hemodynamic responses in patients with HFrEF while exploring the relation between pro-BNP processing and CGMP regulation. So they took two groups. One were a group of 20 controls who had no heart failure or structural heart disease, and they had 15 symptomatic heart failure with reduced ejection fraction with a median heart ejection fraction of 25%. The procedures which were done in the heart failure patients were a baseline right heart catheterization when the patient is clinically stable, and after the initiation of medication, that is either sacubital valsartan or vericiguat, 2 months after that, the second set of values were taken, and simultaneous blood sampling from coronary sinus, artery, and vein were done. The biomarker assessment which was done was CGMP and pro-BNP levels. And this concept of percentage pro BNP is introduced, where pro BNP plus mature BNP into 100 was another parameter which was assessed. So baseline, when they compared, it was seen that there was a significant difference of the coronary sinus CGMP levels, and it was noted to be higher in patients with heart failure. The coronary sinus CGMP to BNP ratio again was found to be significant, and it was markedly lower in heart failure patients, where for obvious reasons the BNP levels were higher as compared to the increase in the CGMP levels. The effects of sacubitril valsartan or vericiguat. So after treatment, the venous as well as coronary sinus GMP levels were increased, and baseline hemodynamics, there was no major change in the cardiac index per se, but the mean pulmonary artery pressure and the pulmonary artery wedge pressure, there were significant changes in the hemodynamic measures or either on when on patient was on treatment with either of those. But between the two, there was no significant difference. The key correlations are that the percentage pro BNP in the coronary sinus is inversely correlated with the coronary sinus CGMP at baseline, and it was significant. And the coronary sinus CGMP to BNP ratio increased after therapy. For obvious reasons, the BNP reduced with therapy. And the change in CGMP minus CS positively correlated with the change in the cardiac index. It was just marginally significant. So conclusion is that cardiac CGMP augmentation, as indicated by elevated coronary sinus levels, was associated with hemodynamic improvement in patients with HFrEF. Both sacubitril valsartan and vericiguat improved the GMP levels and supporting the therapeutic potential in modulating the GMP pathways. And there is an inverse correlation between the percentage pro BNP and coronary sinus CGMP levels because of the impaired pro BNP processing and CGMP regulation in patients with heart failure. And it highlights the important role of CGMP modulation in optimizing the hemodynamics in patients with HFrEF. Next is whether sacubitril valsartan has any significant impact on patients on the sleep apnea parameters in patients with heart failure with reduced ejection fraction. This was a meta-analysis where they took multiple studies from Embase, Medline, and Cochrane, and to analyze the whether there was any impact of sacubitril valsartan therapy on the cardiorespiratory parameters in patients with HFrEF and sleep apnea. They used multiple statistical analysis, and it was seen that there was significant improvements, the significant changes in the clinical and echographic parameters after sacubitril valsartan within 6 months, after 6 months of therapy, with respect to the natriuretic peptide reduction, increase in the LVEF, reduction in the LV sizes, improvement in the RV function, and reduction in the LA volume, and systolic pulmonary artery pressure. Whereas the sleep apnea related outcomes, it was noted that there was a significant reduction in the apnea hypopnea index in patients of sleep apnea with heart failure, and time spent with oxygen saturation less than 90% also reduced significantly in these patients, and oxygen saturation improved significantly. So this conclusion from this study is that sacubitril valsartan significantly improves the cardiorespiratory parameters in HFrEF and sleep apnea. Next is from the ESC Heart Failure 3 registry, where you have to find out what are the important parameters which drive the quality of life in heart failure patients and how it matters. Again, it was a multi-center observational study, prospective study, where it was a registry of patients enrolled with heart failure between 2018 November to 2020 December 31st. And it included all patients with chronic or de novo heart failure in the outpatient settings, acute worsening of heart failure, and across all the entire range of ejection fractions. And also patient was followed up for 12 months. The statistical analysis, important parameters which were noted were the patient characteristics and baseline quality of life parameters. Then any association between baseline quality of life and all-cause mortality, stratified by various geographical, socio-demographic, clinical behavioral characteristics, signs and symptoms. The change in quality of life over 12 months, and whether there was improvement, worsening, whether there was no change. and what are the important determinants in these patient characteristics which affect the change in quality of life. And what was noticed that the most important parameters which grossly skewed the patient away from the center was the NYHA class at presentation. If the patient had class 3 or class 4, patient grossly had a worse quality of life and worse outcomes. And patients on ACE inhibitors, ARBs, and ARNIs, uh, the patients definitely had a significant change. They had a significant positive improvement in the quality of life. They had a better quality of life. Uh, though not statistically significant, we can grossly see that the age is another factor. Like maybe younger age will help the patients in having a better quality of life, but these are all not statistically significant. The effect of beta blockers, the effect of MRAs, although they appear visually appealing, they are not clinically significant. And surprisingly, even SGLT2 inhibitors was not found to be statistically significant, probably because uh, the guidelines regarding the same have changed over the last 3-4 years. The other thing was that patients with heart failure with mildly reduced ejection fraction in women had the highest improvement rates, and chronic heart failure and preserved ejection fraction relatively lower improvement proportions, and acute heart failure patients improved more than chronic heart failure, suggesting that early intervention may yield better outcomes. So this is just a summary slide which is talking about the same factors. And acute heart failure patients which are NYHA class 3, 4, worse quality of life. The lower quality of life predictors were older age, female patients, severe symptoms, and independent factor was baseline for 1 year mortality. Baseline quality of life was an independent predictor. And change in the quality of life, 48% of the surviving patients reported improved quality of life at 1 year. Use of ACE inhibitors, ARB armies, were associated with significantly improved quality of life at 1 year. Last and but not the least, there is this new concept of registry-based RCT, how it is different from our routine RCTs. So we all know about the basic fundamentals of what is an RCT and what is a registry. So this is a appropriate amalgamation of characteristics of both the RCT and registry, so that um, I'm not sitting and reading the individual points, but simple aspects are that the registry-based RCTs, the regulatory procedures are easier, essential baselines and outcome data which are important are focused. It is not driven by a profit. The ethical approvals are not very stringent as compared to the RCTs, and they give a lot of data, and important data can be taken like as that in the registry rather than non-specific data as sometimes which you can get in RCTs, which may not make any sense. And automated collection of baseline and outcomes data, and also it is not that expensive like RCT, and also we can deliver new use of existing drug, and it is quite efficient. As example of a few research models which were on this principle, there have been some Swedish registries which have introduced this concept. So existing registry provides data for power and feasibility, and the results are quite generalizable for the public. And the first registry-based RCT in heart failure and among the first in chronic conditions include adaptable ABC, AF, deliver. They're all chronic but not heart failure. Uh, these are some more studies which are on similar concepts. The thrombus aspirations during ST segment elevation, myocardial infarction, 1 year outcome after thrombus aspiration for MI, instantaneous wave free ratio versus FFR, and oxygen therapy in suspected acute AMI, and bivalvuloridine versus heparin monotherapy in MI. So these are some studies which were conducted on similar models. So though RCTs provide causality and evidence of efficacy, and registries are observational and help understand some analysis of the outcomes and can help in implementation, the a proper suitable amalgamation of the two could be a future better option for countries like us where cost could be a significant issue. Thank you so much.
Thank you, Sriram, for presenting that. So let's open to discussion. So let me start off. Can you switch off the slides, please? So let's start with first paper, long-term safety and efficacy. I mean, what's so new about it, Isram? 135 patients. If you use ARNI, it's likely to be safe and efficacious. I mean, there's a data for thousands and thousands of patients. What's so new about this? Unmute.
Yes, sir. Sir, actually, I felt the same. I saw that it's not something which is unusual. This is just a whatever they had. It is quite proven that ARNIs are efficacious.
135 patients. I mean, each one of us has several times more than that. Okay, if there, let's, in the interest of time, unless somebody has burning comments, let's move on. I am intrigued by the second paper. SGLT2 inhibitors alone are better than the GDMT. How? Can you tell me?
Sir, I somehow feel that first of all, ARNIs were in use for a longer period of time, and SGLT2s have been quite recent, and they have taken the data from 2010 to 2024. And the concept of SGLT2 inhibitors in heart failure has been in the last 5, 6 years alone. Whereas ARNI was maybe the concept of ARNI had come, I think, around 8, 9 years ago at least.
But Sriram,
So,
the SGLT2 trials have been done. You know, there are two huge trials, DAPA and EMPA both. And admittedly, the number of heart failure patients on ARNI were not very large in those patients, but there were plenty of patients on beta blockers and aldosterone antagonists, very large number. And the benefit was shown on top of that. So, Sandeep, do you really feel that now we should ditch everything else and have patients only on SGLT2 inhibitors?
We need to look at this data if they publish it. If they can get it into a peer-reviewed journal, then we need to look at this data because it's just an abstract where we haven't seen the full data.
sir, and
I
one
really
more thing
want to
which
see this
appears
data.
Yeah.
one
Yes.
more thing which appears quite skewed is that the number of patients on SGLT2 inhibitors is around 2,200. Those on full GDMT is only 273, and those on only ARNI is only 346. And with just more than one heart failure, there are 7,991 patients. So how they can be easily comparable, I'm not very sure.
How would somebody be brave enough to put patients only on SGLT2 inhibitors, 2000 patients, not on other GDMT, and then start analyzing the data?
I think there are big ethical issues in this at this point of time when GDMT has to be there. So I think I agree with Dr. Sethi that I think these are all abstracts. Once they send it for manuscript, there can be questions. I think.
Dr. Nabirajan, any comments on that?
Yes, sir. But as you said, the ARNI numbers are very less. The other drugs, beta blockers and other drugs could have been an impact on ARNI. But as you already has mentioned, this deliver trial and the DAPA-HF, they have thrown much light. So in future, SGLT could be a single drug which impacts the whole outcome of the heart failure, sir.
I don't know whether you would be brave enough to discontinue beta blockers, MRAs, and ARNIs and use only on SGLT2 inhibitors. I mean, okay, food for thought, but I think we need to look at that. Finally, next we come to vericiguat plus ARNI. So, what does the paper actually conclude? They did a trial and they gave vericiguat and ARNI to small number of patients who were normal and then also to people who had heart failure. Is that so?
So uh, they are actually the slides which I've received, it doesn't show clearly whether the normal patients were given or were not given. Going by the logic, there was no reason that they should have received either ARNI or vericiguat, a normal patient.
No, unless it is a phase 1 study in which all these kind of crazy things can be done. But is it what they did? I don't know.
They have not given the methodology, sir. We'll have to see what exactly they did because they just have compared. But how you can compare when that they should have ideally given because otherwise they cannot compare whether sacubitril valsartan caused the change.
So, Sandeep, you feel that augmentation of CGMP potentiates the effects of ARNI?
See, basically, if you look at the mechanism, most heart failure medication improves endothelial function. Most endothelial function improvement raises the nitric oxide levels. One of the pathways of improving nitric oxide levels is by the cyclic GMP pathway. So probably if you look at the various pathways which are improved by any heart failure medication, maybe cyclic GMP levels are increasing anyway. So we'll have to look at those pathways.
But then, the thing is, even natriuretic peptides are increased, but not as much as they should be. So same may be true for heart failure and CGMP also, that maybe the levels are more, but using drugs like vericiguat raises it much more. This is what we do with ARNI also. Although natriuretic peptides are increased in heart failure, but we try to increase them still further to derive further benefits. Is that the way you will read it, Shantanu?
I think they are trying to give us a ratio of the coronary sinus, CGMP, and all those kind of things. It's very complicated, but I think how does they're trying to give a dimension that vericiguat and ARNI are already are NO inhibitors. The concept of CGMP that they're trying to do, but I think it doesn't add to the whole anything. There is anything new in that. I'm very. I'm not excited about this trial. That's my personal thing.
Okay.
Very difficult to do.
Sleep apnea, improvement in with the supportive
ARNI.
therapy. So isn't it just due to better heart failure control?
Yeah, I think this
that
is
it
something
does
interesting.
work.
Yeah.
Yeah. Any comments on that, Sandeep or Dr. Nabirajan?
Just better heart failure management.
Yeah.
Yeah.
Okay, then we come to quality of life and heart failure. Class 3 and class 4 were worse. Of course, we know that. What's so great about this? And then ARNI and SGLT2 were better. So we know that. But then in the previous paper, they said that SGLT2 alone is better than ARNI. So
just playing around with numbers.
yeah, I think it's what else? Acute heart failure improved more than chronic heart failure. We know that a lot of acute heart failure patients may have a reversible condition, or at least they improve very significantly. While if there's a progressive gradual deterioration of chronic congestive heart failure, on a long-term basis, they're likely to do worse. What do you say, Isura?
Sorry, sir. I lost contact for a few seconds there. Could you please repeat the question?
So it is mentioned that as acute heart failure patients did better than chronic congestive heart failure. So is there anything surprising about it?
So acute heart failure would have presented earlier they would have presented to the hospital and they would have received more critical care as compared to chronic heart failure where it could have been ignored for a longer period of time. That could be one of the reasons why they improved better.
And many of them could have been a reversible condition.
Reversibility. Yeah.
Definitely.
Sandeep?
That's correct.
Okay. Then finally is registry based on RCT. I'm sorry, I am totally lost with this. How do you do that?
The only
Even I
study I
didn't-
found interesting actually, if you have a very large database,
Yes.
then you can choose a question which is based on that database. For instance, from here you can get that kind of data which they tried to get earlier.
Okay.
If the data is uniform, and then you can find out which drug is better and which drug is worse, how many patients did better on ACE inhibitors or SGLT2, but then the data has to be strong enough that during that period, all patients were getting ACE inhibitors, ARNI, all patients were getting SGLT2 inhibitors. But if the data spans 20 years when all therapy has changed, then that registry will not provide that kind of data. But supposing you choose something simple, uric acid is a prognostic marker. That kind of data, if you have uric acid for all 10,000 patients, you can get that kind of data out from this. If you want uric acid male versus female, you can take out that data. So depending on what kind of data you want, if the data uniform, you can pick out every third patient from that registry and you get a randomized registry data. That kind of thing you can do. So
Was
with
deliver
limited,
done like that?
I don't know. I haven't.
You mentioned deliver, for example, deliver. Sriram?
We can have a look
Sir,
at
it
it.
was
Yeah.
I'll have to go through it, sir, because here they gave it that it is an example of one such study.
Mm.
They have given all those
Yeah,
on
I
that
think
slide.
apart from that, application of artificial intelligence, I think in these data sets is going to play a big, big role. And even this time in ESC, artificial intelligence in heart failure was one of the standout performers. So I think that applications are coming, and I think sooner or later we'll see a dramatic changes. Okay, thank you so much for all the speakers and the panelists and the experts. Any last minute comments from either Sandeep or Shantanu or Nambir Rajan?
I think a couple of changes in pregnancy, myopericarditis, these are important things to be seen, but I was wishing to have better abstracts. There are a few things which are already known, but I think the RCT-based randomization is pretty interesting. So I think we need to have a good data collection, homogeneous data collection. Yeah.
Right. Okay, so with that, I think we come to the end of this session. Thanks a lot, as I said, to the speakers and to our panelists and to the audience who is listening. I hope you benefited as much. You did learn something new. And with that, I think we come to the end of this particular coverage of ESC and seek the success of this. I think we should be doing this for every major cardiology conference, at least 4 that we know of. That is heart failure and the main society meetings, both for Europe and US. So with that, thank you all and over to USV.
Thank you so much, sir. Dr. Vijay Chopra, sir. I would like to start thanking you for making the session so interactive. Thank you so much, Dr. Sen Gupta, sir, Dr. Sandeep, sir, Dr. Nambirajan, sir, for sharing all your expert opinions. And lastly, I would like to thank all the speakers, Dr. Devesh, Dr. Arun, and Dr.
Sriram.
Sriram.
Yes, Dr. Sriram, sir, for being there with us. And lastly, my tech team and our team from PMT, Dharma and Siddhi, for bringing this to us and all the audience for being there with us. Thank you so much.
Okay. Thank you. Good night.
Bye.
Bye-bye.
Thank you.